All right, welcome to our bi-monthly Q&A session with Dr. Wong. No questions have been submitted so far, Simon. So, does anyone have any questions you'd like to submit? Dr. Harbour's in the room. Welcome. If you want to join our panel and have a chit chat with Simon with any questions, feel free to raise your hand. Dr. Janine, welcome. Dr. Lewis. Does anyone have any questions? How's your day been, Simon?
Good, thank you.
Okay. Well, no questions have come in yet. This could be a very short session. Dr. Harbour, you there? You want to join us? All right. I think he's just logged in. Anyone else have any questions? Anything you want to share, Simon, on any interesting cases you're working on, or are we so who might I'm here but at the gym. Okay, no worries. All right. So
next month we've got a 2-day
oh yes.
introduction. So it'd be a good refresher for those of us who have joined us previously. If it's been more than a few years, then there's some new material, especially on the differentiation of genetic versus environmental skeletal growth. So come across some really good research from the University of, I think, Indiana, which helps clarify the understanding of where the environment starts to kick in, where the genetics starts to kick out in growth and development. Professor Roberts has some really good research and some really good understanding in basic physiology and biology to help explain how important genetics is in the first year or so of growth and development, and where environmental factors play very powerful roles from 18 months onwards in a child's development. So actually turns the understanding on the head of most people's misunderstanding of how big a role genetics has and how big a role the environment has. So definitely worth joining in for the research from Professor Roberts.
Absolutely. So do you have any other questions? I know there's some people who've already bought tickets to that event in November. So what you can do to prepare, well, some of you already have access to the recordings from last year, so you can, by all means, take a look at the recordings, so you can kind of warm up a little bit, download some of the handouts. So do take a look at that if you can. I know everyone's busy, so the live stream is 2:30 p.m. Eastern to 10 p.m. Eastern on a Friday and a Saturday, November 7th and 8th. So do convert that to your local time zone. But Dr. Adam Byam, welcome. So for those of you who've just joined, this is our Q&A session. Oh, Dr. Donahue, first time here and signed up for the November 2-day course. Looking forward to it. Yes, absolutely. Looking forward to it as well. We've got Dr. Kevin Boyd, who will be joining us on day 2. He'll be one of the first, he'll be the first speaker, I believe, for about 90 minutes, including Q&A. But predominantly the core curriculum, the core methodology will be taught by my brother, Simon. So anyone with any questions? Do you have any questions, Dr. Donahue, on anything related to, early intervention? Any questions? Dr. Adam, who's, I think, one of our advanced students, welcome. If you've got any questions, feel free to, you can raise your hand and join the panel if you want and have a chat with us, or you can just type any question. We don't have a lot of people here tonight, so do take advantage of the opportunity to ask whatever questions you may have.
For those who have previously finished the programs, whether they be the advanced programs or just the 2-day introduction, we've had some changes to allow people to join the later mentorship programs, the listen and learn process. So some of you will continue on in your training and actually start treatment of patients and want a personalized training and supervision from myself in a group setting. Others are still learning and are quite ready to take the leap into the mentorship, but are stalled in their learning. So we've created a listen and learn category where you can join in on the Zoom video calls where I train the active dentists in treatment of their patients, and you can observe through following the sessions. So you can be part of the learning process without fully committing to starting patients. So it's a really good system to get a feel of how the mentorship program actually runs, as well as a live opportunity to learn via live stream in the mentorship programs itself. So touch base with Kian, and he'll explain to you what's involved, the options for this this learning process.
Yeah, it's been very effective for those who want to go through cases in particular. So since we started the mentoring back in 2020, actually, end of September, we originally started, I started helping my brother March 2020. Well, 2019, we were preparing for our first event in Sydney, in Sydney, Australia. It was planned for March 2020. We all know what happened in March 2020. So we had to cancel that event. But, we refunded everyone and said, hey, instead, do you want to do it on Zoom? And I guess people didn't have any other things to do during COVID. So they said 90% said, yep. So that started our online program. It was due to circumstances. But we adapted and, we started training. Not only after the 2-day introduction, we started doing not only advanced training, different topics, a lot more detail online. We had, when it allowed, we had dentists visiting Simon's practice, dentists visiting the lab where, we're creating all these appliances from. So those were all recorded. And then by September 2020, we started doing mentoring online. There was only about half a dozen people who had cases. Most of them were their own children. That was the first case or two. And so we started the mentoring process, which is now about 5 or 6 hours every second weekend. Twice a month. Simon's on Zoom like this, spending up to 6 hours with about 7 or 8 people. and each person takes turns going over their cases. They're submitting photos, X-ray, Ceph analysis, questions in advance, and they're reviewed. And there's hand-holding, and there's case supervision over 12 to 18 months, and that's all been recorded. And the over 300, we've lost count, 300 cases that have been submitted over the last 5 years, they've all been categorized by Engel's classification. If you just joined us, we're just waiting for questions to come in. No one has submitted questions yet, so please don't be shy. We're just here to sharing some of the journey we've been on over the last 5 or 6 years, and some of the advanced trainings on offer for those of you interested in continuing your journey with my brother, Dr. Wong. But if you've got questions, feel free to submit them in the Q&A box, or in the general comment section is fine. I know a lot of old faces who, been with us for a few years. Dr. Viet, Dr. Cheng, welcome. Dr. Oliveira, welcome. So this is for you guys. Dr. Matomi, welcome. From Cambodia, welcome. If you have any questions, please type them in. This is a limited 45-minute session here during Simon's lunch break. So if you've got questions, either raise your hand, we can join on the panel, or type them in. All right, no other questions coming in yet, but don't be shy. Any questions? So, yeah, so we've recorded everything. And it's not just what we call the case study vault, where you can look up, let's say you have a class 2, div 1 or div 2, and you want to see what other, cases are similar to yours in that category. You look up that folder, everything is dated and classified, and then you can see dozens of examples and progress reports, and everything is documented. The photos, X-ray, Ceph analysis, we've saved them as PDFs, and as we've archived everything's searchable, so you can go back to the archives, and every 2 weeks we've uploaded 3, 4, 5, 6 hours worth of mentoring calls. So that's what we call our case study vault. But there is formal training, right? There's the 2-day program, as you all know. After the 2-day intro, we've got about 30 hours of additional, advanced training that goes into a lot more depth, diagnosis, compliance, the appliances, obviously, and whatnot, case presentation, a lot more detail. What was covered there's only so much we can cover in 14 hours into the intro. But then, as part of the case study vault, that first year of mentoring that Simon did, because it was only half a dozen, he spent half that 3-4 hours. Back then there was only half a dozen people, so we only needed to go for 3 hours or 4 hours. Half of it was he was teaching. It was a specific curriculum. So that first year of mentoring, there's 70 hours of additional, what we call our core curriculum for clinical practice. So this is a specialty. This is, sure, some of you who've got a lot of experience can run with it. If, with the 2-day program, we have what we call like an implementation vault with specific protocols. There's, that can give you step by step, but others want more hand holding, want more training, want more examples, and so on and so forth. So that's where we have that additional training available for those who want to need it. So any questions coming in? Matomi, are you there? Dr. Sony, welcome. Dr. Lisa Jurkovic, welcome. We're just waiting for questions. Otherwise, Simon will have his lunch break. So we shall keep this open for 5 more minutes. And if no questions come in within 5 minutes, I'm going to let my brother go. So there's at least a dozen of you guys in here. So I'm sure there's got to be some questions to kickstart this Q&A. There's only 20, 25 minutes left. So does anyone have any questions? Simon, I mean, while we're waiting for people to, hopefully submit some questions. Okay, we've got a question. Thank you, Adam. Save the day. Okay, so Adam, you've joined our advanced phase one. He's got a question. I'm going to copy this into the document, Simon, 1 second. Okay, can you see that? Okay, you've got that as well. Beat me to it.
Thanks to us for your time. I'm very new to the world also, but I'm wondering, what do you mean by true mandibular rotation? I remember you said something about your study, realizing that it was not expanding the maxilla to untrap the mandible, but that it was more about true mandibular rotation. So the cephalometric evaluation of growing children has been part of orthodontic analysis since the X-rays were invented at the turn of the 20th century. So it's been integral to orthodontics, and started off with the Bolton brush studies. One of the understandings that we have developed over the last 100 years about growth and development of the jaw systems is that remodeling occurs at different components, and deposition and apposition occurs, and the whole shape of the head changes in a very non-linear fashion. It alters its form in a way that isn't a sphere equally expanding outwards. We've learned that it is shape shifting as well as volume expanding. The studies done in the late 50s, early 60s in the Scandinavias by Professor Björk from Sweden used a method of superimposition of X-rays to determine how to realistically understand the direction of growth in the jaw system. And they figured out that in a growing person, there are certain landmarks in the jaw system that are very stable after a certain timeline. That certain timeline appeared to coincide with the eruption of the 6-year-old molars and the permanent lower incisors. They found that once the lower incisors had erupted through, that one of the major landmarks that was stable was the symphysis of the mandible. That region, the symphysis around the chin and the dental alveolar component above the chin, was then used to superimpose growth follow-up X-rays. And it was determined that jaws, when they develop from the receded chin of an infant to a class 1 or a class 2 or a class 3 adult, they could use that superimposition technique to actually figure out the shape of jaw growth and development and understand where it resorbed and where it deposited bone growth formation. They found that the traditional approach of superimposition of, say, SN in cephalometrics, which is commonly used, was not an accurate representation. And the actual growth direction of the jaws was then classified as the true rotation. Jaws in what we call good normal growth. The chin position grows in an upward and forward rotation. So if we're looking at a clock face with the traditional Ceph analysis of the right side of the face, we would be in a what we call a counterclockwise rotation. Right? So this would be an ideal growth direction for the jaw in order to go from the almost class 2 relationship of infants to a normal class 1 relationship with a strong chin, nice bite relationship, good strong AP direction so that even wisdom teeth fit nicely with all teeth in a class 1 relationship. So that was assessed with many, many children in the Scandinavias, and it was determined that class 2 relationships, class 3 relationships, all had different directions of rotation. And the hyperdivergent or the hypodivergent patient, again, had different rotation directions. So they classified the rotation direction in what they call a closing rotation or an opening rotation. So one is a forward rotation in an anti-clockwise direction, and there's another system called a backwards rotation in a clockwise direction. Effectively, if your jaw relationship grew in a clockwise rotation, you would end up with a open bite or a long face, right, or a class 2 relationship. And if your face closed in a counterclockwise direction, your chin would come forward and upwards in a class 1 relationship, or occasionally a class 3 low angle, or occasionally a class 2 division 2 relationship, depending on how the maxilla also rotated in its position. And so the difference between the Frankfurt mandibular angle, for example, plane, mandibular plane relationship when superimposed, when you compared it to superimposition over stable points, such as the symphysis of the mandible, the difference between those two is what we would deem the true mandibular rotation. And it would either show a forward rotation or a backward rotation, and help verify how the jaw system actually grew in the various classifications of normal to malocclusions and so on and so forth. So that's a technical term used to help differentiate the shape changes that occurred from childhood into adulthood. It yeah, so that's what it is. So we go through that in more detail in the advanced phases. I think advanced phase 2, we spend a bit of time going through the research papers that explain that, Peter Bushang and at the University of Texas A&M spent a big chunk of 2 decades of his career as the head of orthodontics in really focusing on taking Bjork's work forward and elucidating the connection between resting posture and true mandibular rotation is the scientific basis for a lot of postural orthodontics. All right. Oh, lots of questions now.
Actually, some of these came from last week that because we had Kevin, we didn't get a chance to answer them. Okay, Candace has
I'm
submitted
sure I've
some.
answered a few of those previously. All right. For those of us early in our postural orthodontic journey, what's the most effective way to communicate the value of growth guidance to parents, especially when traditional orthodontics is cheaper and more familiar? How do you recommend framing this approach so it's not against orthodontics, but rather beyond alignment, emphasizing health and development? The most important thing to understand is the most important thing to understand is to clearly understand the different roles genetics and the environment has in growth and development. Too often we fall back on the default, the easy, you're born that way. When you're born that way as your default, there is no correction of malocclusion. There's only management of malocclusion. And management is extremely time sensitive and cost effective analysis driven. Correction, if you choose to correct something, is whatever it takes to make the wrong right. Right? It's not driven by efficiency, it's not driven by time, it's not driven by cost. It's just you have a problem and you fix it and you do whatever you need to do. Management is juggling to make things acceptable. And you've got a much bigger push for efficiency, effectiveness. And if we accept malocclusion is purely genetic, then management is your only solution. And when management is a solution, you're choosing the most cost-effective, the most efficient timeline to work from. There's no point working in primary dentition because that's not your end goal. There's no point working in mixed dentition because it's just a jumble of transition times. There's no point waiting until full adulthood because your childhood, the teenage formative years have passed and you're miserable because your presentation is less than optimized. So orthodontics, given that it's historically driven in the last 2.5 decades with a pure genetic emphasis. So we've made a decision, 13 is the best time to step in to manage the aesthetic and the functional imbalances. When you understand that the role of the environment is actually extremely powerful, and you can explain where the environmental factors impact not only with dental alignment, but jaw growth and development and general medical health, then you can explain the rationale behind why we might step in and assist this growing child's issues much earlier than the standard 13 years of age. What I hope my teaching will provide you guys with is that knowledge base to understand where environmental factors are extremely powerful and where timeline-wise in growth and development, if we step in and alter the course of those environmental factors, you can have enormous effect on dental alignment. You can have noticeable effect on growth and development of the jaw system, and you can have life-changing effect on medically related issues. We may not necessarily, as dentists, be involved in the treatment of medically associated jaw issues, but we can certainly refer to our specialist medical colleagues that can help. So that's the process behind why we can incorporate early interceptive, early intervention ortho in the larger umbrella of mainstream orthodontics. We're not going against orthodontics in any way. We are understanding the pure role of orthodontics in the teenager, and we're understanding growth and development and how the genetic and the environmental factors influence that child's growth and development. And we are screening for all the factors in the early years that will have long-term implications to that growth and development. And we are treating with the appropriate protocols and methods, with the appropriate associated professionals to ensure that that child's growth is as smooth and favorable as possible. As a pediatric dentist, new in interceptive ortho, I have trouble treatment planning class 2 with mandibular deficiencies. In my recent cases, I've expanded the upper and lower, but the mandible still has stayed receded. So one of the things that we have to be mindful of is to differentiate the structural components of jaw systems. We need to be able to understand that the jaws are separate structures, individually growing with no connection. We have to understand that they're two separate systems of bones. We have to understand that there is a transverse dimension, that there is a sagittal dimension, and there's a vertical dimension, and there's a time or age dimension. And there are 4 separate dimensions in the growing child. Each of those have ties to each other, but they are not linear ties to each other. And developing one dimension may or may not impact the development of another dimension. We have to remember, for example, that the transverse dimension is not the same as the sagittal dimension, which is not the same as the vertical dimension, although they have an association. We have to understand that if we use an appliance that acts predominantly in the transverse dimension, which is what we would call an expanding appliance, it theoretically and practically often has no influence on sagittal dimensions. Right? So why am I saying this? In the question that you've posed, you're saying that your primary problem is that you have a class 2 relationship with a mandibular deficiency. Okay? What does that mean? It means you've got a short little mandible and you've got a big overjet. So then you've said you've expanded the upper and you've expanded the lower, but the lower still is short and stumpy, right? So that's the gist of what you've said. So let me ask you, from a purely practical perspective, how does making something wider lengthen it? Right? From a logistic perspective, from a logical perspective, from real-time perspective. If I go wide, should I expect it to also get longer? And the real answer is no. You're just developing in one direction, right? If you have an X, Y, and Z axis, if you increase the X axis, does the Y axis have to increase as well? Not necessarily, and not certainly in the same proportion that you would change one dimension. And that's the reality, right? When you use mechanics, which is expansion, to develop one dimension, you should not expect any other dimension changes. In postural orthodontics, we tackle those three dimensions in a timely fashion with different techniques. We use expanding appliances to tackle the transverse dimension, and we train children to improve their posture to tackle the sagittal and the vertical dimension. In my practice, when I put an expansion appliance in, I expect to get transverse space, but I do not expect any improvement whatsoever in the sagittal dimension, and I expect a worsening of the vertical dimension. Because when you put appliances in someone's mouth, you worsen their posture. When you worsen their posture, their chin falls down and back. Yet, in my practice, I get an improvement in chin position. And the reason is I also work on a child's posture so that I strengthen their posture so that I get a forward true mandibular rotation, and that brings their chin up and forward, improving sagittal and reducing vertical. And so if you are just focused on the mechanics of widening, do not expect an improvement in depth and certainly expect a worsening in height. But if you follow my protocols, then you can get an improvement in width, in depth, and a reduction in height. And that's the ultimate goal. Understanding the true nature of each of the deficiencies being posturally driven by being weak posturally driven by having an open mouth resting posture. Closing the mouth in a closed mouth resting posture improves the forward rotation of true mandibular rotation and improves chin position, which is actually the primary driver of final adult chin relationship. Okay, last question. What's your sequence of appliances for class 2s? What do you recommend when the mandible does not grow or grow as fast? The reality is I've just answered that question. Right? I'll widen with my appliance, and then I train the posture to be closed to encourage true mandibular rotation to be forward rotation so that the chin grows upwards and forwards. That's the sequence of my appliances. I make it wider, then I train children to stay closed so that their chin grows upwards and forwards. And that is the entire philosophy of postural orthodontics and why postural orthodontics seems to be very successful consistently in developing corrections in AP and vertical dimensions. I've got 2 minutes, so I can answer the next question. How often can we activate cat wires? So I'm adjusting cat wires on every session. Every time patient comes in, I'm adjusting the wires so that they sit nice and snug. I may or may not activate them. I may do a small activation each time, but the cat wires are designed to be active in the expansion process. So generally, I'll let the appliance self-activate those cat wires in the expansion of the screw. And once I've developed the dimension, often I'll be halfway to where I want to be with the incisal position, because I'm adjusting the cat wires constantly to have maximum contact with the teeth that I want moved. At the end of that expansion phase, then I will manually adjust the cat wires, and every time they come in, I'm making a small adjustment. The question is less likely how often do I do it, but how much do I activate? And it's usually about the somewhere between a half to one thickness of the dimension of the wire. The wires are usually 0.8 or 0.9 millimeters, 0.8 for the lower, 0.9 millimeters for the upper. So just under, somewhere between half mil and 1 mil of activation if I'm doing a manual activation. All right, and that comes to the end of our session. It's a shame we spent the first half of it not going through questions, but we've got 45 minutes. Make the most of it, guys. All right, excellent, guys.
All right, thanks, Simon.
Thank you.
For those of you just joined us not too long ago, we're here every couple of weeks. The next session will be, should be in just two, actually, let's see if the date's right. In 2 weeks' time, let me see. Yeah, it should be in 2 weeks' time. Give us a few hours. Probably by tomorrow, we'll have the link where you can register again. It's always the same link. Right? So I want to give it to you guys here. That's the link. Thanks, Adam. Thanks, Sonny. Also, while we're here, we have our second for the year 2-day program, and we decided to do something we've never done before and offer the lowest price ever for just the live stream. We've broken it up in different components, so some people don't want all the fancy bells and whistles. They just want to attend the live stream, and this is $97. It's a special. We're running until the end of the week. So it's great for a refresher. A lot of you guys have already attended years ago and spent, you know how much you guys spent for that. Anywhere from $700 to $1,200 for just even a live stream, or 2,000 or 3,000 for the in-person events that we've had. So if you want a refresher, just $97. If you want the recordings as well, there's an extra 100. We're going to be doubling the prices end of the week. You can see it doesn't come with any of the protocols, the slides. Those are additional. So just attend. If you've never attended before, you can just get the VIP ticket with the recordings or a live stream. If you have attended before, you've probably already downloaded our slides and practice templates and whatnot. They're obviously a lot additional to these basic prices, and you can wait till you attend the event, and if you like it and you want to actually put things into practice, there's obviously additional fees for the additional support, right? We've got a private Facebook group, et cetera, et cetera. But if you've already attended in the past and you just want to attend again, $97, all right, until the end of the week. So it's a good refresher. If you've never attended before, give it a shot. It's $97, 30-day money back guarantee, and it's a good way to dip your toes into early intervention. On that note, good night, everyone. Thank you all for attending. If you have any questions, I'll be more than happy to answer them if there's any questions, but if not, otherwise, feel free to send us an email. It's info@straight teeth naturally. Oh, one final thing. for the first time, Simon has decided to open up some consulting. So if you have any particular cases you want Simon to review, where you need to submit photos, X-rays, F-analysis, and so long as you've done the 2-day intro program, he's happy to. It doesn't have to be your own child. It used to be very strict. He had limited times that if it's their own child and they're wanting to look at treating their own children, he's happy to do a one-off consult. But we just decided we can open up if you've got a particular case that you want his opinion on. You can apply, get a consulting slot. So just reach out to me and I can give you all the details, the pricing, and so on and so forth. So that's info@straightteethnaturally.com. Yeah, once again, the case study vault, if you're interested in listening in on the live mentoring programs and get the most comprehensive training, that's our new case study vault. So drop us an email. We can give you some details about that also. All right, yeah. So on that note, have a great evening, and we'll see you in a couple of weeks, or hopefully in about 2.5 weeks. There's our 2-day program. It's the second time we're doing it this year, but should be a good one. All right, thanks everyone. Good night.